I think I think I'm live now. I just wanted to go over just one quick topic about the pathophys, symptomatology, and various methods of hearing evaluation for sensorineural hearing loss and conductive hearing loss. This is coming from the primary care textbook, the Dunphy fifth edition. So this information is out of the Dunphy book. So that's where I'm getting it from. Jumping right in, we're page 296 to 298. So sensory neural hearing loss is defined as a lesion in the organ of Corti or in the central neural pathways of the ear, including cranial nerve 8 and the auditory cortex. So age-related hearing loss, which we can call presbycusis, is a form of sensory neural hearing loss. It also may be a result of Meniere's disease or be noise-induced from acoustic trauma. Sensory neural hearing loss is usually irreversible, unfortunately. So some causes, like we talked about, presbycusis, Meniere's disease, tumors, maybe acoustic neuroma, some medications that are ototoxic, aminoglycosides, aspirin, and quinine, trauma to the ear or head, diseases like syphilis or viral infections such as mumps. So presbycusis, it's typically a high frequency hearing loss that is bilateral. So yeah, we have the bilateral hearing loss. Meniere's disease causes fluctuating hearing loss. It's usually unilateral, and it's associated with tinnitus and vertigo. So maybe they have some ringing in their ears and they get dizzy and have the nausea that comes with vertigo. And then acoustic neuroma, termed schwannoma, is a rare tumor of cranial nerve 8, and that one causes unilateral, constant, or progressive hearing loss. Possibly can be associated with a headache. I mean, it's a tumor. Think about it. With a tumor of the acoustic nerve, there will most likely be neurochanges such as facial weakness, tingling, a loss of taste, and dysphagia, in addition to the hearing loss. Conductive hearing loss, on the other hand, results when the passage of sound waves through the tympanic membrane in the inner ear is impaired. So normally sound waves travel from the external environment through the ear canal to the tympanic membrane, where vibrations are transmitted across the middle ear by three delicate bones, the ossicles, the malleus, incus, and stapes. We remember that from like elementary school. But we remember those things because they're important. Conductive hearing loss may occur at any age due to factors that reduce flow of sound waves through the ear canal across the tympanic membrane into the middle ear ossicles, those three little bones. Good news, though, conductive hearing loss is often reversible. Causes could be a cerumen impaction, you got a bunch of wax in there, perforation of the tympanic membrane, maybe chronic ear infections, congenital abnormalities, otosclerosis, or tympanosclerosis, or you can have temporal bone fractures or other injuries that cause that conductive hearing loss. So we go to our subjective piece. So patient could complain of just difficulty hearing, possibly pain in the ear, pressure, discomfort, vertigo, loss of balance. They may also complain of like tinnitus, dizziness, blockage, popping, pressure, crackling, distant sounds, or stiffness. So then we would obviously question them using the old carts, ask about how long they've noticed the hearing loss. Is it partial, complete, one or both ears? Ask about the family history or personal history of surgery or ear trauma. Also, something to think about is you can ask them about serious illness or infection where they could have been on antibiotics that damaged their ear. So the ototoxic antibiotics that we talked about. So review systems should focus on neuro, including the cranial nerve function. We talked about cranial nerve number 8 specifically. The social and personal history should include specific questions regarding noise or toxin exposure, especially like any blast-related injuries, history of hunting, target shooting, We know that when we're shooting guns, we need to wear some hearing protection, but sometimes that doesn't happen. So that could be cause for problems. We want a complete history of uh, prescription and over the counter meds. Now we know that can be difficult, but we can just do the best we can to get that from our patients. Um, Objective, we need to be looking inside their ear, obviously. We're inspecting the external auditory canal and the middle ear. We're noting any redness, foreign objects, discharge, scaling, lesions, and cerumen. The tympanic membrane should be intact with no perforation, should be a translucent pearly gray. Conductive hearing loss occurs when a sound transmission is impaired through the external or middle ear, like we talked about, just to recap. And sensorineural hearing loss occurs because of a defect in the inner ear that leads to distortion of sound. So, some tests that we can do. The book suggested the first test is the Weber test. So we hit our tuning fork. It's specifically a 512 hertz or higher frequency tuning fork, and we place that midline on the patient's skull, and just ask them if they or feel the vibration. Normally, the vibration should be heard equally in both ears. So for the Weber test, if the patient's having sensory neural loss, the sound in the unaffected or less affected ear is louder. So, say I have a tumor in my right ear. So, the vibrating tuning fork would be like super loud in my bad ear. But, oh, wait a minute. I screwed that up. It would be louder in my unaffected ear. Alternatively, in conductive loss, the sound is louder in the affected ear. So, um, sensory neural loss, Weber test, sound in the unaffected ear is louder. Conductive loss, the sound in the affected ear is louder. Moving on to the RIN test, that same vibrating tuning fork is placed on the mastoid process. When the sound fades away, um, without restriking it, you put it over the external auditory meatus. Normally, the sound can be heard for twice as long via bone conduction, so you kind of have to time it out. And I know there's other YouTube videos you can look at to kind of get a better idea. And I didn't really understand the book's description of this, but it says in sensory neural loss with a RIN test, the ratio remains the same. So I guess I need to look into that a little bit more. And then in conductive loss, the ratio is closer to 1-to-1 or even reserved. So to me, that kind of sounds like the same scenario, but check out RINNE test. That's just one of the tests we can use. And we need to look into that further. So, Strawback test. This is also one I need to look up on YouTube because I really have never heard of it, but it's where you have that same vibrating tuning fork, place it over the mastoid process of the patient. And when the patient says they stop hearing the vibration, then I, as the examiner, would take and place that same thing over my mastoid process to see if I could hear it. So it's a little bit of a different funky test, but so in sensory neural loss, the patient's bone conduction is present for a shorter time than the examiner's bone conduction. So in that case, I would still, as the examiner, be able to hear that vibration. In conductive loss, the patient's bone conduction persists for a longer time than the examiner's bone conduction. So I wouldn't be able to hear it anymore. So that's just kind of a review of the hearing loss types and how to test it. So there you go.